Hi, I'm Xian Xiao.
And I'm Sammy Winemaker. We talk to people who have information and tips on how to unlock a better illness experience.
The waiting room revolution starts right now. Hope you have had a great summer. So excited to restart weekly episodes of The Waiting Room Revolution. We have an exciting fall lineup planned. They feature more intimate conversations, longer episodes, and diverse guests from all over the world. Hope you enjoy. Welcome back to The Waiting Room Revolution. We are excited to have Dr. Kwadwo Kyeremanteng on our show. He is an ICU and palliative care doctor from Ottawa. He is the founder of Resource Optimization Network, and probably most people know him as the host of the popular podcast, Solving Healthcare. He's the leader of Quadcast Nation. So Kwadwo, welcome to our podcast.
Yeah, and Sammy, that was a legendary intro, man. Like, it makes me want to jump up and applaud or something. I'm feeling good after that.
You know, the funny thing is I wanted to kick it off with, on your show, you talk so much about changing healthcare, community action, and you always spotlight your guests, but you don't get a lot of time to talk about yourself and your story. So I'm really excited to get to learn a little bit more about you. And you're an ICU doc who's also a palliative care doc. How did you start the palliative care route?
Yeah, so thanks for that question, because I think it's it's not intuitive to a lot of folks that as a critical care doc that you would do palliative care. So it was twofold. One was one of the docs that I wanted to emulate. His name was Dr. John Seeley. He was a legend as far as I'm concerned. Former Dean of Medicine at University of Ottawa, former nephrologist. And I witnessed him in action. I remember the first time we were at the sticky end of life circumstance where there was a lot of, there was a lack of harmony between the care team and the patient's family. And when Dr. Seeley walked into this room and had he was a big man, but had this presence, this calming presence, this like overwhelming feeling of, guys, it's going to be okay. We're here to take care of this. We are here to take care of your loved one. Hand on the patient's shoulder, showing that empathy, that compassion. And I was like, this is what it's all about. This is why we got into this gang. This is what to be able to alleviate that suffering for the patient and the family by how they carry themselves, how we carry themselves, how we communicate. I thought this is something that I want to be able to emulate. And then within critical care, people don't realize about 15 to 20% of our patients pass. Mm-hmm. And this is going to be an unpopular opinion, but I don't think most of the stuff that we do makes a difference. Like, if you have intensive care doc A versus B versus C, most likely your outcomes are going to be the same. Mm-hmm. And so to me, one of the most important ways of alleviating suffering was how you communicate, how you address families. And so that skill that you acquire through palliative care on how you could be such an effective communicator with families and the patients was such a valuable tool. Because when we ask ourselves, yes, we've gone into this profession, like like to be a physician, to save lives and to also alleviate suffering and make sure that the patients and their families don't go to unnecessary amounts of suffering. And when I saw the Dr. Seeleys of the world, their approaches, I'm like, this is what I want to be able to offer our patients. And so that was essentially my journey. It wasn't one of those, I wasn't one of those docs that said throughout his career from the gate, this is for me. I want to be a palliative care doc through and through. It came relatively late, but I'm super appreciative and glad that it's been part of my life.
I was going to ask you, do you ever get an opportunity in critical care or in the ICU with these folks who have not just chronic conditions, but they're progressive and eventually life limiting, and they get worse and worse over time? Are you ever able to have discussions with them about where they're at in the big picture of their illness. Why is this admission to the ICU different than the one last month or 3 months ago or 6 months ago? Are you ever able to put their current exacerbation in perspective in terms of where they're at in the illness journey to help them understand?
I mean, there's certainly opportunity to, I think one of the challenges is within critical care, and, I hate to say it, but there is a bit of a bandwidth concern, when you're dealing with anywhere from 10 to 15 critically ill patients there, say that said patient was intubated, you might have the discussion with the family about potentially it being a one-way extubation. In other words, just, the plan to not re-intubate. But in terms of how it's been with that specific patient, their journey, often we're not having an opportunity in the heights of their illness to be able to have that conversation. And then as they get better, you extubate them, and, within a day or two, they might leave your ICU. They might not be they might not have the mental capacity to have those discussions, or we get caught up often in just the other patients that are, that are more critical at the time, and we seek more of their attention. But to be honest with you, I think back in the day, this is why some of us were pushing for some more palliative care involvement, almost like criteria-based involvement in our ICUs, because I think within ICU, one doc is there for a week, like 7 days, right? So we don't have necessarily that continuity. And imagine if you have an embedded and integrated part of your ICU, that palliative care presence. So when said patient gets extubated, and they're going to the floor, there's that potential continuity that patient will have somebody that has seen their journey and is following through, and can have those discussions, can have that rapport, you know what I mean? And build on that. Because I think in ICU often, because you have the one doc that's there for 7 days, and often if I meet that same patient and it's day one of my week, odds are we're not having an in-depth conversation about how their journey was during that admission, or, you know what I mean? So not to get us off the hook, because I think what you're bringing up, Sammy, is very important. I'm just bringing up the practical aspects of it.
Yeah, sure enough. I mean, there's so many immediate issues that need to be taken care of. You need to be in the weeds of the illness when the person's in critical care. And I'm asking you questions about the forest and not the trees. And it's true, there are all these practical barriers. What ends up happening is the baton gets passed from team to team, hoping the next team will have that big picture discussion until I meet them at the 11th hour in their home. And I ask them, how much do you understand about where you're at in your illness? No idea. I have no idea.
Yeah, it's sad, because I think some of it, I think often is, when it comes to some of these chronic conditions that might be a little bit more tougher to prognosticate compared to, say, your, late stage malignancy, the late stage cancer. But you're right. How often are we having these discussions? How often are we passing the baton on? And, I think I'd love to have a more systemic, high level discussion on how we can really eliminate, make it happen actually. And because I do have several ideas, once again, having palliative care embedded within the ICU, I think to me is genius. So it's like a ton of win-wins, not only from the communication piece, but even the pain and symptom management. Sometimes that could be optimized, not all. Yeah, I often think that could be an area that could be enhanced. But yeah, for me, it was always all about that continuity. And we've done a few research projects looking at, when you have that that high level of palliative care presence within ICUs, the benefits that we've seen, not only from a satisfaction point of view, but also from an ICU length of stay and actually cost savings related to having palliative care more integrated into your ICU.
Yeah. And so that is what we have been talking about, Sammy and I, for years and years. And that's how we came up to create this podcast, right? The waiting room revolution. And the name really came about the idea that we have spent so much time trying to do education for clinicians and focused on healthcare providers and administrators, that on somewhere along the way, we lost patients and families and their voice and their agency to create change. And so one of our big ideas of how we can go upstream and provide a palliative approach to care, even before they ever reach critical care, was to give patients and families skills. And that was really the focus of our season 1, with all these metaphors and skills that people could learn. And so I wondered what you thought about this idea of focusing on patients and families and sort of like teaching them how to have serious illness conversations, how they could lead them, how they could initiate them, how they could learn how to ask questions so they could zoom out into the big picture of their illness. Because that's a challenge, right? I mean, changing physician behavior or system behavior it's entrenched. So I guess the idea of focusing on them, do you think that's a possibility for change?
You know what, CN? Like, I think that's a really brilliant approach. And, you know, we're seeing more and more patient and family engagement when it comes to research, quality improvement initiatives, like hospital planning. And it's because their voice matters and because they can amplify, man. Like, you've seen it on Twitter, you've seen it on social media. They can really amplify messages and I think when you want to address such an important concern in healthcare, like end of life care, you want to be able to hit as many channels as possible. You know, and from my perspective, I'm a big believer of really empowering healthcare professionals, just because I do think that is an extreme amplifier. Like, when you can engage young family docs, the value of having these vital, essential conversations, wow, like that could be a powerful tool as well. So really, I think you kind of go by multiple fronts, but specifically that idea of engaging families, empowering families, and getting them enlightened to ask these simple questions. Like, they're sitting at the table with grandma and say, like, yo, we haven't discussed what you would want at the end, especially in the context of your COPD or heart failure. You know, like, I think this would be absolutely powerful.
Mm-hmm. You know, because we found that patients misunderstand their diagnoses sometimes, and they think that they're just chronic and going to remain stable. And they have such blind trust in the healthcare system and their trusted doctors that they just passively float along their journey and don't even know what they don't know. And at some point, at the end of a progressive life-limiting illness, which can be months or years later, suddenly someone says to them, there's nothing more we can do for you. And it's like a slap in the face. They get a label called palliative, and they look back and think, wow, what did I miss here? And so what we're trying to do is empower and activate patients and families and teach them skills that will allow them to come to the healthcare system, like you said, amplified in numbers, and force the healthcare system to begin to face both hopefulness and truth-telling when it comes to progressive life-limiting illnesses, because 90% of us will die from one of these illnesses. Only 10% die suddenly.
Mm-hmm. Wow. No, I think such an important initiative. And, you know, I kind of just, I don't know, it got me a bit sad or thinking about that experience for some of our patients of, you know, thinking about this, having that lens of, yeah, this is a chronic condition that I'm going to live with for a long period of time, and us not really doing our best to communicate like what it actually means to have COPD, what it means to have congestive heart failure, that this is a terminal illness, what it means to have dementia. You just put a lens on the fact that we could all collectively do better. And because I got to tell you, so many patients and families, they want to know the truth. They want to know accurate information so they could plan, they could connect with their loved ones. They could have that, and I don't want to take this the wrong way, but that gift of knowing, like, you might not have that many summers left. So what are you going to do? You're going to really take advantage of this summer. You're going to travel if you want to travel. You're going to talk to that cousin that made you laugh. Cousin Ricky, who's hilarious. Always takes off his shirt at the dinner table. I want to go see Ricky again. So I think what you're saying, Sammy, really reigns true.
Because if we don't offer that, then we turn the opportunity and the gift, like you said, the silver lining of time and knowing, into a crisis, because we turn a situation that can be calm and planned and proactive into one crisis after another, and with no one able to catch their breath. And then suddenly you see in the newspaper, Aunt Bessie died suddenly of COPD, or Charlie died suddenly of heart failure. Well, guess what? No one died suddenly. They've been dying for a while.
100%. I mean, we see it all the time in the intensive care unit. Like when we have those outreach calls or rapid response calls, race calls, patients, and often, I mean, to be honest with you guys, like there are times where we go into one of these calls on an oncology ward, and with their stage 4 malignancy, I'm the first one telling them that this is a terminal illness. You know what I mean? So yeah, it's just a wasted opportunity, a lot of undue suffering, unnecessary suffering, a lot of unnecessary pain, because people got to realize when you land in an intensive care unit, this is not easy. If you end up on a ventilator, you can't communicate easily, you can't express pain, you can't express anxiety, you can't express shortness of breath, you can't scratch your nose if you want, you can't deal with your thirst. When we hear about our patients and their PTSD and their anxiety and depression, if they do survive, like there's reason for that. And so, when you have that option of really planning your death and having your being able to make sure that your symptoms are well managed and you don't have that unnecessary suffering, that is a completely different picture. So this is why I think a lot of us feel so passionate about empowering families, empowering healthcare providers, clinicians to be able to provide that kind of care for our patients.
So much of what you talk about on Solving Healthcare is about community engagement, but you also have a lot of guests who talk about policy change and provider behavior and system change. So I'm wondering if you've ever felt there's like a tension there, the bottom-up approach or the top-down approach, and if you think there's one way that's better at making change than the other.
Yeah, that's a good question. I'm not sure about the tension. Like, I don't know if I've noticed it as much, but I certainly, if I were in charge of anything, I'd be more of a fan of the bottom-up approach, man. Like, the closer you are to the roots, the more accurate, the more appropriate solutions come to play, in my humble opinion. You know what I'm saying? Because I think. Sorry, go ahead.
I said I do get that, but do you ever feel that the system doesn't get it? And I'm sure many of your guests are have jumped onto the co-design bandwagon, but I feel like the majority haven't. And especially if you look at policymakers and the way we sort of run the system, it isn't patient focused. I mean, I think you'd agree.
That's fair. Actually, if you think about, I guess I'm thinking about, depends how high of an admin level we're talking about, because if people were really serious about this, that, you know, like it's like, I think at a ministry level, like at a provincial level, there's way more that could be done, and way more support that could be offered when it comes to palliative care needs and end of life care needs, and addressing advanced care planning and so on. But I'll reinforce, honestly, if I'm trying to find out, if I'm being serious about solutions to problems, I want to be at ground level for sure. Not and like all players, not just like the patients, the caregivers, sometimes even, you know, depending on if it's a palliative care ward, personal support workers, like all levels, because there's so many insights there. There's so many insights on ways that we could provide enhanced care to our patients. But yeah, I do think, now that you phrase it like that, CN, that is fair. Like there is, you know, hey, this is what we think is going to work. Hey, you know, maybe there's some suggestions we're hearing from the ground, but, you know, maybe we think we know better because, you know, there's a lot more masters and MBAs and PhDs at the table. But yeah, that's a hard problem to fix.
But when CN brought up the word tension, it got me thinking about what other tensions exist in critical care and ICU. And one of them, I can't help but think about the person in bed D, or whatever you call them. What do you call them? Pod A? What are they called? Pods? Rooms?
Oh, room.
Beds?
Yeah, like,
yeah, room. Like room A versus, you know, Mr. Smith. Like the person versus the condition, because when they come in, they're in such rough shape. Do you feel in a way that critical care healthcare providers almost have to disassociate from the person that they're working on or trying to heal as an object versus a person?
Very, very good, insightful question. And I'm not 100% sure on the answer for that. I can speak from my own personal experience with this level of years behind me. Having people more personalized is fine for me. Like I in fact, I prefer it. I did a show with Dr. Lynn Ashton. She was at the time first year resident, and she had suffered a cardiac arrest, left her quadriplegic. And on the show, she was just talking about how crappy it felt when she was referred to as bed 32 and depersonalized. And I've never forgotten that. It's one of the things that kind of stuck with me to really say, hey, you know, what is that patient experience like, and why can't we do better? Let us do better. Let's use their names. Let's know a little bit more about them. Let's not call them by their disease state. And so, you know, the worry is that you do get a little too close. And, you know, I think the skill, if anything, is kind of in the moment, you don't get too personal, but in the right time, you bring that personal element, like you decompartmentalize when appropriate. Because I'll tell you, when you want the intensivist that 2 seconds ago, yeah, I might be telling Mrs. X that her husband is dying, and then 4 minutes later, when an upper GI bleed is coming, you don't want me thinking about Mrs. X. You want me on point, yo. Like you want me like focused on the patient that is bleeding, and thinking about, you know, how I'm going to manage the airway, where are the blood products, how, am I like orchestrating the team well, am I leading the team well, what other hands do we need on deck? Like all that kind of thought and diligence needs to be in place. And so this is why I think the skill, in my opinion, is to kind of compartmentalize when needed, but obviously when you're in that family meeting, when you have the time to unwind, or what's the word I'm looking for?
Debrief.
Debrief. Thank you. When you debrief, that you feel it. You're in it at that point. You're there sharing with your team. You're there sharing with those that are struggling. Because I think you need that to actually stay healthy and stay engaged. But it's I mean, what I personally teach the residents, or the kids, I call them, is that yeah, we're gonna try and personalize things appropriately. That's Mrs. J, not bed 32.
So I want to talk a little bit about your podcast. You've been doing this for a year and a half. It's a very popular podcast. You've had some really exciting guests. What have you learned from your guests? It's funny because like when we did this, we had a message that we wanted to get out. And I feel like all the guests we have, we're learning from them, just as much as we're trying to get a message out. Like we're inspired by them too. So I wonder if you've had the same reaction of all the guests you've had, if you feel like there have been, your eye-opening moments that really changed how you think with your guests, and to share some of that.
And so in terms of like lessons, my God, my favorite topic has been patient experience. So I told you the story about Lynn Ashton. I interviewed a friend of mine, Dr. Jen McComb, about her experience with Henry. He was 8 months when he was diagnosed with neuroblastoma, and lessons I learned from that. Like she gave an example of the care team not saying hi basically on a weekend when things were busy, and how it impacted her and the anxiety it brought to the table. And I've never forgotten that. So, every day when I can, no matter how busy it is, just popping your head in and saying like, things are a bit crazy right now, but if there is some questions, I'll try and get back to you, or let the nurses know, like that, like the little things, like these things, that the lessons you learn from some of your guests. Oh man, we did an interview with Chika Oriwa. She's the first Black valedictorian. She just graduated in 2021 or 2020, sorry. And man, we did that interview post George Floyd, and she moved me, man. She really pushed me in saying like, all of us that have a position to advocate for our people, we need to step up. And so that's when we started the Black Mentorship Program, which is alive and thriving. To answer you directly, is that I have learned a ton. It's changed me. It's made me a better clinician. It's made me, I didn't know I had this much of a lead, like an ability to lead. I didn't know that was in my capacity, and this is what it's given me the ability to do. It's given me courage. It's given me the ability to advocate and have a voice, and it's honestly it's been an absolute blessing that I'm so grateful for.
I wanted to ask this question, and it's kind of twofold, because you talked about the Black Mentorship Program, and on your website there's a lot of stuff about racism in medicine. So I guess my question is, what is the message that you want others to hear about this?
Oh man, do we have time? It's so many things, Cian. Like if I were to give a condensed version of what I want people to know, it's that racism in healthcare is an issue, whether it is the patient, whether it's the provider, it's present. Whether you're Canadian, American, it is absolutely present, and it's something that we all need to be aware of. And by increasing that awareness, we're more likely to do something about it. So that's always been my approach, is like, hey, I'm going to tell you my story so you have a better understanding of what my struggles were like, what my fellow BIPOC physician healthcare providers have gone through, because everyone has their story. There's nobody that doesn't have that story. There's not a single Black doc I could tell you that's never been asked that they didn't want to be treated by a Black physician, by a patient. I could guarantee there's been docs out there that were being called racial slurs outright at work, that have not had mentorship opportunities, that have had to work extra hard to get into their position. You know, you've witnessed patients go through discrimination them in and of themselves. Like one of my most inspired interviews also was with Dr. Mike Curlew and his experience with Indigenous health in Sioux Lookout. And I was baffled and ashamed not only to be Canadian and hear that stuff like this was happening in our own country, but that I didn't know about some of these horrible occurrences. Like did you guys know that up into the 1980s that Sioux Lookout had a segregated hospital, for example? Like you would have a white hospital and an Indigenous hospital. And you don't need me to tell you what kind of care people were getting in the Indigenous side of the Indigenous hospitals. He's telling me stories about running out of medication for patients, whether that's antibiotics or sedation or analgesia, having to put patients, like having to paralyze patients and not have enough pain medication. Like this is in our own country.
Wow.
You know? And so, I mean, we've seen the George Floyd incidents, we've seen the rallies, we've seen the statements by all these organizations. And what I always tell, like I give a lot of talks on this, is like when it comes to our white colleagues or white people, have a lens of compassion. Every person of color that you've seen has a story, and it would put you to their knees to express some of the stuff that they've gone through. So come at it with a lens of compassion. Don't give me this all lives matter crap. Like, of course, all life matters. When you hear someone say Black Lives Matters, they're not saying Black lives are even equal. They're just saying they matter, and that shouldn't be controversial. Shouldn't be controversial for a young Black man to go on one knee to show his discontent for police brutality. Like, we're above that. Show that compassion. Be patient. Have that level of understanding. Want to advocate. Want to be an ally. Call it out when you see it. There's nothing worse than having to be put on the spot when someone does a racist statement or gesture, and having all that pressure put on that person of color to save face and represent everybody. Like, show up, you know. And people of color, what I always say to them now is aim high. This is your time to aim high and know that you could get a seat at the table. And yes, you're going to struggle. Yes, you're not going to have much mentorship. Yes, you're going to feel alone. But when you get there, because of the resilience you've established, because of the body armor you've developed, because of what you've gone through, you will become strong. You'll become a leader. You'll become a legend, and you'll be able to advocate for your people. And so, this is what I feel strongly about this now. Like, this is the time, you know, collectively, white, Black, you know, BIPOC. This is the time that we push when there is that momentum to create that change. That talk of EDI, this is the time to create that change. And I'm sorry I'm rambling. It's just because it's such an important topic. But embrace diversity. I promise you, the more diverse you are, the stronger your organization is, the more increase in perspectives, the better care, the better ideas, the more innovative you're going to be. Like, diversity is a power, and embrace it.
You talk about diversity being a superpower, and I think that's such a powerful quote. And I also think that information is power too, especially in the context of end of life and medical assistance in dying, right? Or MAID. I think we find people are lacking information, and that's why they're requesting it. And we often think palliative care is about complex symptom management, but so much about it is illness understanding and sharing information and the big picture of the illness.
It's awful because that amplifies physical symptoms. right?
Totally.
When people are anxious and scared, and when they're not sleeping at night because their mind is wandering into the future and they can't land because it's so foggy, and every doctor or nurse tells them, sorry, I don't know. I don't know. I don't know. Well, someone's got to know. And then we get called in because people are asking for assisted dying. And it's legal, it's a person's decision, but isn't it such a shame that some people might ask for assisted dying because they don't even know what to compare it to, except for where their mind is leading them down horrific places, because no one's bothered telling them that actually the biggest symptom of dying over months is fatigue and low energy and needing more care. But people don't know that. They just compare, assisted dying with horrifying, excruciating symptoms that crescendo until the last minute. Who wouldn't want assisted dying?
Yeah, this is a very good point. It made me think about something Cien mentioned before in terms of lessons I've learned from hosting the show, and this is a lesson from palliative care as well, but how holistic we really should be and need to be when it comes to caring for our patients. It's not just the analgesia, it's not the pain meds, it's not just the dealing with their anxiety, it's everything. How are they doing spiritually, mentally, physically? Are they sleeping? Are they eating okay? Or like all these things impact their well-being and their perspective, and all this stuff leaves an impression. And you're right, if you don't deal with a lot of these concerns, of course they're going to think about how to like other means that's outside of palliative care. And so I think this is why I think it's so important to really educate and engage our young healthcare providers coming through about some of these approaches, about really looking at the overall well-being of our patients. Well, I mean, not just once again in the palliative care setting, but through chronic disease and so forth, because you'll get way better results if you take that time.
If I can, this is exactly why, the heart of our work to redefine palliative care, because people think it's about the end of life, and to improve the end, you've got to go to the beginning. And part of that means we have to use different language, maybe. But really, everything you talked about, the holistic view of the patient and their uncertainty, that happens right from diagnosis, oftentimes, of a serious illness. And it isn't only the end that we're trying to make better, the last weeks or month. It's the whole journey, which could last years and years. And so much of what the waiting revolution is about is going upstream and helping people in some ways innovate or redefine a palliative care approach, so that not just from their ICU doc, but from their primary care, from their cardiologist, that they can balance between, the best treatments and technologies, but also have an understanding of where they're at and making the best choices that fit who they are. So that's been so much of what we're doing, is moving not just palliative care at end of life, but going upstream, and how to do that successfully that is optimistic and hopeful and not seen as something that, people want to avoid.
I love this topic because it's like one of my favorite, I don't know what the word is, not hobbies, but areas of medicine, I guess, or parts of my job is really to try and innovate, like really think about ways to really encompass such creative and well thought out, like, or well-intentioned ideas that deep inside that are going to work well for patients. I mean, if we even use a data-driven approach, we had, there's the Tamil study with the non-small cell lung cancer patients. When they had that early intervention with palliative care, had lived longer, ironically, when palliative care was involved, which is ironic, but not super ironic if we think about it once again, because we're adding that holistic element to the care. But knowing that, ironically, it's still a battle. There's evidence out there, and it's still a battle to get us involved early. But I would love that discussion about how you can really get buy-in about having us involved in patients' journeys earlier. And I don't know if it's models of care. I don't know if it's mindset or culture. I don't know if the name needs to change and like a reset. There's so many ideas of how you could approach this, but I think it's only creating potentially win-wins for patients and care providers if we were to implement this downstream earlier. Is it downstream or ups? No, downstream. Sorry, I get metaphors mixed. Did you say up or down?
Up. I think up.
Earlier. Let's just say
earlier.
Earlier.
Yeah, I'm the worst like sharpest tool in the shed box or whatever. Like all these metaphors, I mix them and I'm horrible. But
I love it.
Yeah.
Kwadwo, this is our entire podcast is about this. The whole piece of how do we do it and how do we go upstream has been our mission from day one, because we've read the studies, we do the studies, we've done the education, and it's like it's not working fast enough. It's not that it's not working, but it's definitely not working fast enough. And we needed a new approach and new language, and we needed new people. That's why it's patients and families. They're the new army to demand a different answers to the way that we're doing things.
I love it. No, I'm hearing this. I'm loving it, because one thing in medicine we do is we approach things the same way 58 times and expect different results. Mm-hmm. And I like the way that you're telling me you're switching gears. It's like, you know what? We're not making that much progress. Like, honestly, we're not. So let's think of a different approach. Let's engage family and see, like, they're getting more juice. Families getting more like their ability to advocate and pump out stuff is becoming way more powerful than it was 5-10 years ago, especially in the context of social media and so forth. All these groups, like this is actually a brilliant, more that I think about it, it is brilliant to try and approach it this way. I'm excited to see you guys' journey for realsies.
There was a time Sian and I both felt like, throwing in the towel at both of our careers, Sian as a researcher in palliative care and me as a palliative care physician, because we just didn't see the dial changing fast enough for the amount of work we were putting into it. We, meaning collectively, we. And so, we, took a giant leapfrog over the healthcare system, and, a little bit of a vulnerable shift we took, bringing, what felt like at the beginning an expose about healthcare to the public in a way with this podcast, and saying, it can't be that you may or may not get what you need because you happen to get the right doctor or the one who's willing to go there with you. That's just not fair. So we said, we're cutting out the middleman. And this is what you need to know that no one has told you. You didn't even know you had to know it, hoping that they're going to rush the healthcare system with a completely new vibe. And so whether they get a palliative care consult early, middle, or late or not, that they will be able to leach out of any nurse or any doctor the information that they need to connect the dots along their illness journey and to balance hope and reality, so that along their illness, their hope can evolve and match where they're at in their illness without having to ever see a palliative care team.
That's beautiful. And because I was just thinking too, as you were saying, these, like, empowering the patients and families, I was thinking how, like, for us, we realize conventional ways of trying to change culture or how to innovate, it just is too slow. Like, honestly, like when it's research, like the traditional medical medical approaches, it's way too slow.
Mhm.
And you think about this, how many people are reading that journal on
Mhm.
in palliative medicine or what have you, compared to, say, listening to a podcast, especially one that you can easily circulate or even, put on multiple social media platforms. You saw COVID really put an eye for me in terms of med Twitter on how you could really amplify any message or idea through social media. And the other one too that for me was, I was late to the party, was like mainstream media. Actually, like if
Mhm.
they have a story on, how difficult it could be for families to navigate some of these palliative care issues, that could be an extreme amplifier.
Mhm.
And once again, a lot more people are seeing that compared to, the journal article in palliative care medicine. It was just something that, I wish I would have been more attuned to maybe 5 years ago, but it's better late than never. But holy cow, it does take outside the box thinking to really create some change.
Mhm.
We, I'm looking at the time. We often try to end our interviews with, what advice do you have for others, for patients and families who are just starting the journey from everything you've learned?
My advice is, I think is twofold. One, as a person that traditionally is, I think some of my friends might think contrary to this, as a guy that doesn't often like to ruffle feathers, if there's a time that you need to advocate for your loved one, it is during this journey, this end of life care journey. Whether that's you don't think they're getting an adequate pain and symptom management, whether their home care needs aren't enough, whatever it might be, this is the real time to, in my opinion, where you bolster up that courage to advocate for your loved one, because this is a time where you will never forget. This is, your loved one is dying, and I must say, when it comes to grieving, like I say selfishly, as a man that has lost his father, and has deep regrets on how that went, I would say, that's the time you step up. You do all you can to advocate, and be there. And then, for the same kind of lens for the healthcare providers, remember, we have such this emphasis on, saving life, doing everything you can to save that life, and that's a strong message even in medical school. What I will say is, near end of life, you treat that as urgently as and as importantly as you are when regards to trying to save a life. You want that patient experience, that family experience, to be pain, like to be as painless, as symptomless, as sufferingless as possible, because there's going to be a lasting memory for that family. So you do what you need to do to alleviate suffering. If you need to get out of that call room and see that patient and make sure that those symptoms are being addressed, you do that. Imagine that's your mom. Imagine that's your dad. You step up. Yeah, that's what I would say.
Kwadwo, thank you so much for being on our podcast.
Yo, let me
Oh no,
just say this.
Yeah, go.
Awesome job and awesome content what you guys are throwing down. I am so proud of what you guys are the messaging, the content, what we call it on our show, we call it changing the boogie, like trying to innovate. You know what I'm saying? I'm like, it is a true privilege to be on here, and I can't wait to have you guys both on solving healthcare. We're going to continue to change that boogie together, yo.
Thanks so much for listening. Please rate, review, and subscribe to our podcast and help us get the word out. Our theme music is Maypole by Ketsa. The podcast is edited and produced by me, Sien Xiao, and Kayla McMillan. Special thanks to Krista Honstra, Principal of Clarity Hub. Please go to our website to join in the conversation, waitingroomrevolution.com.